Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Sam Mazer, and I'm joined tonight with our producers, Hartley and Crystal. Say hi, guys.
Hey.
Hello.
All right, so our guests tonight are Dr. John Ackerman and Elizabeth Kleinhenz, here to discuss suicide prevention and safety planning. But first, let's remind you about the show.
We are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation tonight with our two guests, Dr. John Ackerman and Elizabeth Kleinhenz. Dr. Ackerman is a board-certified child clinical psychologist who works at the Center for Suicide Prevention and Research at Nationwide Children's Hospital. In that role, he coordinates community and school-based suicide prevention efforts across Ohio, supporting nearly 300 schools and implementing prevention models that are evidence-based. He is faculty on the Pediatric Acute Care Clinical Psychology internship track, and he leads trainings on suicide and safety planning in healthcare, school, and community settings. Elizabeth Kleinhenz is a clinical social worker and an avid podcast listener who works in a pediatric primary care clinic in Columbus, Ohio. There, she supports children and family with a range of psychiatric, developmental, and safety concerns. She is particularly passionate about primary and secondary prevention in all forms in the primary care setting.
It's safe to say that this is going to be a good episode.
Hi, Dr. Ackerman and Ms. Kleinhenz. Thank you so much for coming on the show. First, because we're just an informal group, is it okay if I can call both of you guys by your first names?
Yes, absolutely.
Perfect. Thank you. Okay. So this is when we generally do these get to know you questions, rapid fire. And because we have two guests, we'll kind of divide it up here. Maybe John, we'll start with you. Generally, we want to give a rapid fire kind of get to know you. Generally, we do a one-liner, almost like it's in medicine. Anything that you like, anything that you do, maybe something outside of medicine that interests you.
I'm a pizza making, dad joke telling, family advocate, dad of two.
Amazing. Amazing. Tell us more about the pizzas.
Definitely make it from scratch. Make those since COVID. We've been doing pizza nights every Saturday night. So I've got that from scratch. Got my 1,000-degree uni oven and fire them up.
Not that this is a commercial for uni, but no, that sounds really, really good. I heard that it's actually harder to make pizza dough than it looked. You have to let it rise for certain times. There's different types to it. Do you make a specific type of dough that we should all follow your instructions for?
I like a Neapolitan style, and yes, you have to think about it. The downside of usually when you want pizza, you're not thinking that 24, 48 hours, but that's how you got to roll. So as long as you have it in the fridge, you let it rise and you get a thin and crispy is what I usually like. And I like a cast iron deep dish as well, but that's a separate process.
Nice.
Wow, you really know your pizzas.
That's it. We can just end the pod there. It's all about
Exactly.
pizza. Now everyone's an expert.
That is the nice thing about, hey, Saturday nights we're going to do it. So you make sure on Thursdays you're good to go, get the whole thing prepped. I like it. I've actually just learned about some of this pizza stuff just recently. And so now I realize that it's way harder to do all these things. And now I'm a lot more impressed with every single person that does that. So
like everything though, the practice, you just keep getting easier and more automatic.
I was like, practice makes dinner in this case.
I love that.
Exactly. All right, Elizabeth, what about you?
Hi, my name's Elizabeth. I am a social worker in a pediatric primary care office. One thing that I really love doing in my spare time is bike riding. And I've recently been getting into rowing when I go to the gym. Like a full body workout. It's really gets cardio and strength at the same time. I just plop myself down. There's a little phone holder, watch some Netflix, and I just row. So those are some things I've been getting up to lately.
Do you ever row boats, Elizabeth? Is that the next step?
No. I would if I, maybe had the opportunity with like a group of friends or family or something, but I have like never gotten to that point yet.
That's fair.
I'm rowing machine at the gym is a little bit more my speed.
That's fair. I did grow up in Columbus, Ohio, and I can vouch that there's not a ton of ocean around Columbus, Ohio.
Yeah, I grew up in Worcester, Ohio. There's even less ocean there. No, no rivers, no lakes.
Oh, they do the Big Ten Regatta right in Columbus, right along the river, about 5 minutes from where I am right now.
That's awesome. That's next for you.
Yeah, exactly. I was going to say, I had this terrible story of trying the erg machine in college and just not having fun at all. But I think it's now upgraded itself to putting a phone holder where I can watch a TV show. I think that would change the game.
The phone holder really is the game changer.
Yeah,
I have to say, because it's like, oh, I'm just going to go home tonight, sit on my couch and watch Netflix. Why not go sit on a rowing machine and watch Netflix? And that way I can get some movement in
and watch it
at the same time.
Exactly. So you're being productive.
Been my thing lately.
You're being productive watching this television. That's perfect. All right. We have a ton to cover, and generally with two guests as well, we have a lot of questions that we want to ask both of you guys. So we'll probably skip our rest of our questions. For any listeners out there who really want to know, feel free to send us an email, and we'd be happy to include best advice and favorite failure at a different time. But in the meantime, Hartley, what do you think about this case?
Yeah, let's go for it.
You're a devoted clinician. Your patients get your best. But if you're finishing charts and admin work during nights and weekends, it's time to meet Freed. Freed is more than an AI scribe. It's an AI assistant that writes your notes, automates coding, creates referral letters, patient instructions, answers medical questions, analyzes patient history for smarter visit prep, and pushes everything into your EHR with one click. Freed can be used across all specialties for in-office as well as virtual visits and works in over 90 languages. While it takes only minutes to learn and requires zero IT setup, Freed's white glove US-based success team is available within minutes for every customer, no matter the size of practice. Join 26,000 clinicians who get to focus on patients, not paperwork. Use code FREED50 for $50 off your first month at freed.ai. That's freed.ai, freed.ai.
So today you are in the Kashlak Pediatrics Clinic where you meet Aiden and his mom for a well adolescent visit. Aiden is 15 and he has a history of mild depression and anxiety that was diagnosed last year. Since then, he's been seeing the counselor at his school every couple of weeks. Your last visit with him, you talked about SSRIs, but Aiden and his parents were pretty worried about side effects, so he ended up not starting any medications. Today, you're looking at Aiden's PHQ-9, and he scored 16, including answering sometimes to the last question, which is thoughts that you'd be better off dead or hurting yourself in some way. So when you're talking with him and his mom, he tells you that his mental health is okay, but when you interview him by himself, he does confirm that he has thought about hurting himself and he has engaged in some self-harm behaviors, including cutting recently. So let's start from the basics. John, would you be willing to just walk through what does it mean when we talk about non-suicidal self-harm?
Sure. So non-suicidal self-harm is any time an individual intentionally causes themselves injury or inflicts harm without an intent to die. So there's a distinction between non-suicidal self-injury and suicidal thinking, suicidal ideation. So the challenge is that the two of those constructs are related. One, if one's engaging in non-suicidal self-injury, it actually puts someone at higher risk for suicidal thinking and actually attempting. But if we're going to just talk about non-suicidal self-injury, or some folks refer to it as an SSI, that's when a person is looking to serve some sort of function by causing them harm outside of a desire to end their life. And that could be trying to regulate intense emotions and not having other alternatives to do so. It could be about, kind of controlling things that seem really difficult to control. It could be about feeling something. It could be a range of different functions, all of them which are usually what we think about as a less than helpful or adequate, effective way of coping. So that's probably the start.
Yeah, and then I'm curious, When I think about non-suicidal self-harm, I usually think about cutting. Are there other forms of non-suicidal self-injury that we should be aware of and should maybe be asking adolescents about?
There are many, and since this is an adult audience, I could share some of them with a young person. I would give them a laundry list of ways you could harm yourself. But there are a number of ways that individuals engage in that self-injury. Also worth noting, and I didn't mention that earlier, actually, non-suicidal self-injury is much more common than suicidal behavior. Actually, about 1 in 5 teens engage in non-suicidal self-injury. So it's fairly common. The prevalence is high, and in terms of a lifetime prevalence, but it could look very different for different folks. I think self-cutting is the most commonly thought of. It can also be sort of burning, engaging in hitting, banging, or other sort of destructive behaviors. It could look like even freezing or sharp objects and different things to inflict pain. There's even things like piercing could be viewed as self-injury if it's a specific targeted way of harming oneself. So I won't go on with a much broader laundry list, but yeah, depending on culture, depending on different circumstances, sex differences, there are different ways that people injure themselves.
Gotcha. Thank you for going through that. Yeah. Elizabeth, would you be willing to talk us through sort of the relationship with non-suicidal self-injury and suicide? I think, John, you were already kind of trying to get at this, but I'm curious how you think about the relationship between the two.
So I would start by saying that they both share some common risk factors, and that non-suicidal self-injury is also itself a risk factor for suicidal behavior. So like John mentioned, non-suicidal self-injury is far more common than suicidal behavior. If we look at those who engage in non-suicidal self-injury, in general, those who start non-suicidal self-injury at younger ages, and also those who continue non-suicidal self-injury over longer time periods, are generally at increased risk of progressing to a suicide attempt in the future. There is some evidence that engaging in non-suicidal self-injury can lower the inhibition for a person to engage in a suicide attempt. Just getting over that initial threshold, so to speak, of causing injury to your body can be, aversive and difficult for a lot of people. So once that kind of barrier is broken, even in the form of non-suicidal self injury, it can make it quote unquote easier or less aversive to engage in a suicide attempt in the future.
If I could add, I loved how Elizabeth phrased that. And from a suicide prevention perspective, when we're looking at self-injury, it is that sort of behavioral rehearsal and sometimes escalation that we worry about, that someone's now, they're viewing themselves as sort of solving their pain problem with taking it out on themselves. And also, as they move forward and escalate, and maybe that self-injury doesn't meet their immediate needs in the same way, it may move towards a sense of hopelessness or helplessness in dealing with that pain, which can then lead to some suicidal behavior.
I think for me, when I'm seeing patients in the clinic and I see someone who's had these behaviors, I'm kind of stuck as to what do I do now? Like, what kind of next steps, Elizabeth, might you lay out for the pediatrician who's coming to you and saying, hey, I've seen these behaviors, maybe on the physical examination, I'm seeing kind of physical changes, like, maybe I'm seeing the scars. Like, what are the next steps that you recommend for following up if this is something that we uncover in our visit?
Great question. So I think when we first uncover that a child or an adolescent is injuring themselves in some way, it can be helpful to start by finding out whether that was suicidal or non-suicidal in the intention. I have had many children and adolescents, for example, who describe cutting themselves as a suicide attempt, and many who describe it not as a suicide attempt. So if you, as the pediatrician, are noting scars or other forms of injury, I think, providing an empathic response to the child, noticing that they've, got some injury and getting curious with them about what happened and kind of what was that behavior like for you. And, when you injured yourself, were you trying to die? Asking them that direct question can be very important. If a pediatrician discovers that one of their patients has been engaging in non-suicidal self-injury, my next steps would be a couple things. Number one, trying to understand more about their mental health symptomatology and kind of what cognitive and emotional experiences they're having that has led them to engage in that behavior. This could be a window or an entry point into understanding if they're having increased depressed mood, if they're having increased anxiety, if they're having relationship challenges, things of that nature. I would also want to separately screen for suicidal ideation because, like we were just talking about, if we know that a patient is engaging in non-suicidal self-injury, that is a risk factor for suicidal ideation and suicidal behavior. So that would prompt me during my exam to administer a separate screening for suicidal ideation and then kind of progressing from there. In terms of brief interventions, things that I commonly will do with children and adolescents for non-suicidal self-injury, try to get curious about that emotional experience that they're having when they self-harm and trying to find healthier replacement behaviors. A coping skill that maybe from a sensory motor standpoint feels similar or provides the same type of emotional relief, but it is a safe way for them to release that emotion. So I'm just going to give a brief example. If a child, for example, shares that they are cutting themselves when they have intense episodes of anger, I might work with them to find a safer thing they could do when they feel angry. Maybe instead of cutting themselves, they are throwing a pillow against the wall. Maybe they are ripping up a piece of newspaper. Maybe they are taking some ice and like crunching it up in their hand and like throwing it as hard as they can into the bathtub. This is something that still kind of quote unquote meets the functional need that they are having in that moment that needs to be expressed, but in a way that will not injure themselves.
Crystal, it's a great point of, seeing these scars or something like that and realizing you need to bring this up. We kind of talked about this in the context of a patient that we are going to talk about depression and depressed mood. You brought up, sorry, Elizabeth, about if like you should get into the emotional health that's going on right now, try to figure out the symptomatology, that type of thing. When I think of a differential diagnosis almost backwards, are there any other disease processes that I should be thinking of when someone's cutting themselves, or should I always be thinking depressed mood in kind of in that capacity? Because if I am always thinking in that capacity, I can jump right to what you just said, kind of open up that screener. But if I should be like, oh, you could also have, psychosis, for example, I should be, broadening my differential. Just before we move on to how we're going to get better from these things, I was just curious if you guys had, this is always with depressed mood, or is there a differential diagnosis for the mental health disorder that would come with that?
I will just jump in briefly and then please, John, take it away. I would say the short answer is depression is very common as a kind of co-occurring mental health process, but it is by no means the only mental health process that can accompany self-injury. And I do believe that that could be a misconception, that a person is automatically depressed if they're engaging in self-injury. That is not true. While it is common, it is by no means the only. So I would not start by assuming depression. I would ask them about their mood and how their mood has been lately, but I would not stop there. I would also just very briefly look at a few other key symptom clusters. So I would be also asking, a big one could be impulsivity. Have you noticed that you're feeling restless? You're having these big emotions and it's hard for you to know what to do with them. You're taking risks. You're acting without thinking it through first. I think impulsivity is a big one. I would also ask if this is comfortable or feasible or possible for the pediatrician in question, asking about a trauma history. I do see that trauma is very common in self-injury, so that could certainly be another symptom cluster. And then maybe, at least in my practice experience to a slightly lesser extent, but still noteworthy, is anxiety. I do see a lot of kids who are having maybe very somatic manifestations of anxiety, things like panic attacks or even just chronic generalized anxiety where they've got these butterflies in their stomach. They've got this kind of restlessness, this psychomotor agitation, this kind of like low-grade irritability that they can't quite shake. And then that can produce kind of like a physical urge to release that in some way. So mood is where I'd start, but that's not where I'd finish.
John, I don't know if you had any other thoughts, or we should take it from there.
Yeah, and I can also add, I thought that was wonderful. I do think the mood disorders and anxiety disorders are most common, but there's also, in addition to trauma, there's various like repetitive body focused conditions like hair pulling, skin picking that you might want to rule out. They tend to have more of an anxiety focus. So I think really thinking about what the function of the self-injury is for the person, I think is really important, and then being able to look into what the other possibilities are.
Awesome. So I think, obviously we are talking about this case in the context of a breast mood. So let's kind of bring it back to that. And so, John, this is maybe more for you. When you think about this patient, we've already gone through hurting himself, showing some self-harming behaviors. Before we get into kind of our suicidal ideation here, we're just kind of talk a big picture about therapy because we have an opportunity to speak with psychotherapists today. We've talked before in other episodes about SSRIs and other types of antidepressants from a medication perspective. But when you talk about psychotherapy choices, what specific types of treatment might you recommend? What are you thinking of when you see these types of patients?
The evidence for depression and anxiety conditions is strongest for one of the family of cognitive behavioral therapy approaches. So especially for younger kids, the most randomized control trials support the use of those. Now, once you start to look at non-suicidal self-injury and suicidal thinking, the amount of supported treatment starts to go down, unfortunately, and they start to be a little bit more intensive treatment. So we know that dialectical behavioral therapy, for example, is one of the more effective treatment approaches, and that does involve looking at things like mindfulness, emotion regulation, interpersonal effectiveness, and distress tolerance. That's a lot of jargon, but what it means is helping a person be present with their emotions, learning how to manage the ups and downs of their mood, knowing what to do when those urges to harm oneself really pick up, and feeling like I can do something to distract myself. I can do something to delay that message in my brain that says the only way you're going to get through this pain is to harm yourself. So there are some treatments that are informed by those principles that work really well. But if we are dealing with something with depression, you usually are dealing with that cognitive or that triad of depression, which is thoughts that I'm not good enough, I'm a burden, I'm worthless, the people around me don't care about me, and the world is hopeless. So you've got these really challenging cognitions that you're up against, that a therapist can really help you identify veracity of those claims that your mind is making, and then actually get you doing stuff, actually get you being more activated, taking charge of that sense of hopelessness that nothing I do matters, and challenging that by doing. So a lot of the most effective therapies are exposure based, which means you're not usually just going to engage in that talk therapy for a bit and tell the client something that they haven't thought of before. Most of the time we're like, oh, you should just I know the joke is like, just do yoga, you'll be fine. It's that those types of behavior activations can be helpful, but it's usually also about giving the person a sense that that they can be effective in their own lives and how they've been managing things. And especially if you're talking about something like self-injury, that, like Elizabeth said, there are alternatives, and we've got to test those alternatives out to see if they meet your needs in a way that allows you to start to feel better about your capabilities. And again, so it's not about just talking to the person, tell them that they're good enough. It's not a Goodwill Hunting moment typically. It's a let's go, let's try this out. You and me, we're on this team, and we're going to experiment with different ways of navigating your depression until you feel like you're the master. So I'm not the sage on the stage. I'm the guide on the side. I'm the person who's over here helping you make progress in your own life and to become more of a master of your own decisions.
I love that. I love that model of like walking with patients through the steps of what we actually need to do to help figure out where a good place for them to be is. So I wanted to bring us back to Aiden and his mom. So you're still talking with him, and he ends up telling you that he actually quite often wishes he could just go to sleep and never wake up, which is sort of the first time you've heard him express out loud something that you feel like feels like suicidal ideation. So let's start with Elizabeth. How do you define the concept of suicidal ideation?
So, suicidal ideation is thoughts of wishing to be dead or ending one's life. Um, it can take a wide variety of forms. It can manifest as a lot of different thought processes. It can vary in intensity, it can vary in duration, it can vary in co occurring symptoms, like we were talking about earlier. There's really a lot of like phenotypic variety with suicidal ideation. But in general, it's thoughts of wanting to end one's life or wishing to be dead. So, yes, the statement that Aiden is making about wanting to go to sleep and not wake up is, in fact, a form of suicidal ideation.
And following up on that, I often hear in clinic active versus passive suicidal ideations. Are these important distinctions to make, and how might you define them?
I love this question. I'm actually really glad that we brought it up. So, active and passive, in my practice experience, is language that is often used. I will say I've heard some different definitions of what constitutes active and passive. Generally speaking, what in my experience, people use the word active to refer to having thoughts of killing yourself with some intent to act on them. That's kind of the most frequent way that I see the word active suicidal ideation used. However, I will say that there's some like variance there. So I think it can be important when you're consulting or communicating with other practitioners. And if they were to use the word active suicidal ideation, I think it would be helpful to clarify what exactly they mean by that. Passive suicidal ideation, I've heard it defined either as thoughts of wishing to be dead, but not necessarily wanting to kill yourself. I've also heard it defined as having thoughts of killing yourself without intent to act on them. So I don't think that there is full alignment in the field on the way that these terms are used. John, I don't know if you have anything to add on that, but in practice, I would say the best recommendation would be to clarify these terms when you are discussing them with other professionals so you could be on the same page.
Yeah, I think all of that was right on target. I think there's a few distinctions in terms of what those active and passive thoughts are correlated with as you think about as you add more intent, as you add more specific planning, as you add more chronicity and severity, the likelihood of that ideation turning into action or behavior is higher. But we also, when we're training with schools or primary care providers or clinicians in our hospital, we don't want people to be lulled into a false sense of security that because this person wants to go to sleep and not wake up, and they didn't have a specific plan, or they didn't tell you that specific plan, that you're all of a sudden in the clear, and this person does not represent a harm to themselves. So I think it's good to know these distinctions. It's good to know that, yes, if there is an active plan with a method and a time frame and a sort of something that's been rehearsed, that is highly, highly concerning. And but for most of those levels, even within the passive domain, you would still want to have a clear sense of the details around it and a safety plan to make sure that that they have a way of navigating this. And ideally, I think when we started to talk about Aiden, the idea that he's disclosed this to you, that it's in itself is a big step and warrants validation that he has now shared with you one of potentially a darker, in his mind, secret, something that is often labeled in a way that stigma doesn't allow us to share with other people, in a way that others in his life may have rejected. They've now talked to you as a provider. That's a big deal. You've established some nice trust, and they're coming to you likely having thought about whether to share this with an adult for a long time. So the fact that you've actually created a platform for them to share this information is really a good thing, even though in your mind as a clinician in a fast-paced environment, you may think, oh, shoot, this is going to be an extra long session, or this is going to require safety planning, or this is going to be it. Like, keep in mind what an important moment this is for that individual who just decided to share. And think about yourself in that moment, what you can do for this person, but also understand that your reaction to this person may guide how they interact with the healthcare system for years or a lifetime to come. So not to put extra burden on
no
folks,
pressure.
This is if you respond compassionately, as Elizabeth suggested, you can really set a person up for actually navigating this challenging mental health condition.
Yeah. That's a great point and a great reminder that I think for many of us, like an anxious or depressed teenager is like very routine in some ways. And to them, it actually feels like the biggest thing in the world, because it is. I have a couple follow-up questions. I'm curious. I've heard you use the phrase suicidal behavior a couple of times, and it sounds like you're using that in a more specific way than I might use like active suicidal ideation. Can you maybe, John, just define like suicidal behavior?
Yeah. So, and this differs across countries. Like Europeans say like self-harm all the time to refer to all that cluster of behaviors. I try to make a distinction to be as specific as possible between suicidal self-injury or suicidal ideation and suicidal behavior, with the ideation being the thoughts, the planning, the considerations, and the behavior as being any attempts, any plan, and any sort of rehearsal and activity. And that would fall under. And then suicidal, I'll just add that we didn't add this in the beginning. Suicide just means any small part of the person wants to die, which is an important distinction because a lot of people are ambivalent and they're not sure if they want to live or die. So if any part of the person may want to die, like that go to sleep and not wake up, that actually falls into the suicidal category. Whereas non-suicidal self-injury and non-suicidal behavior always involves no intent to die whatsoever.
And then one thing that this may be a bit of a tangent, but one thing that I've encountered more from parents than from maybe teens themselves is this idea of like self-sabotaging or behavior that is that appears to disregard concern for potential life-threatening consequences, especially when it comes to substance use or driving in risky situations or putting yourself in risky situations. I'm curious if in your practice you consider some of those behaviors to fall under suicidal behavior, or if for suicidal behavior you have to be actively seeking out some kind of self-injury. Does that make sense? Elizabeth, you seem like you have maybe some thoughts on that.
Yes, this is a great question. I'm thinking through the most kind of organized way to answer this. I would say that, short answer, I would say yes. To me, depending on the person's thought process, if any part of them, was kind of disregarding the possibility of death, comfortable with the idea of death, maybe part of them even was welcoming the idea of death, I would call that suicidal behavior personally, because I think the thought process behind the behavior is most important. I think the behavior itself is a little less important, actually, and the thought process behind it is more indicative of kind of the need that person is having.
I would just add that everything that Elizabeth said was accurate around that being a suicide attempt, those situations where a person's ambivalent about wanting to die, using substances. That's probably more common than we'd like to consider. Suicide among 10 to 14-year-olds is already the second leading cause of death. Third from 10 to 24, or if we look at that age range. And what we know is that a lot of these actual counts by coroners, medical examiners, these things are underreported, because the only way we already described, the only way you can determine something to be a suicidal thought or behavior is if you know the intent. The only way you know the intent is if you have some access to the person's thoughts. And a lot of times, if there's an impulsive suicide attempt, there's not a trail. Less than a third of kids leave notes, for example. So you've got this underreported, underrecognized event that only comes to the surface when a person's willing to go to a trusted adult. Even less likely to occur if we're talking about certain racial and sort of ethnic minority groups, certain other groups, including LGBTQ youth. So there's a lot of individuals who would be less likely to share this. However, I think if there's any sort of ambivalence, but the person doesn't care if they want to live or not, that's typically classified as suicidal behavior from like an epidemiological point of view.
Hey, Cribsiders listeners, whether this is your first episode or you've been with us since day one, you know our goal has always been to share real wisdom about practicing medicine. So let's talk about something that actually changed my day-to-day as a hospitalist, and that's FIG scrubs. I can't walk into a clinic or hospital without seeing people in FIG scrubs, and I get it, I wear them too. They're incredibly soft, form-fitting, and durable, and it's not just dust. If you've been watching a certain popular ER drama on TV, yep, they're in FIGs too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids and kids come with messes, I love that FIGs are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine well over 50 times and they still look brand new. All of that and so much more is why we've teamed up with FIGs. Now, Cribsiders listeners can get 15% off. Just go to wearfigs.com and use code FIGSRX. That's WEARFIGS.com and use code FIGSRX for 15% off.
And John, I wanted to continue this thought of under recognition. What are the things as pediatricians that we should be thinking about as risk factors? And you also had highlighted some of the disparities that we often have, and even our best efforts to recognize it, that in some groups that suicide might impact in different ways, or how we're thinking about it, or who we're thinking about, who's at risk. And so I was hoping you could help paint a picture for us, kind of thinking at the, from the epidemiological perspective, what are the risk factors? Who should we be talking about suicide with?
We're not particularly good at predicting suicide risk even within subgroups that are at higher risk. We're not great at identifying who specifically is at risk based on the set of risk factors that we have. So I do want to put that caveat in there. Like, even the risk factors we're talking about, like say, being a male, for example, like might confer a greater risk. That's still goes from a base rate of like 10 and 100,000 to, maybe 2 or 3 times that. So when we talk about risk factors, we still want to think about universal screening. We still don't want to use our gut in determining who's at risk. All that said, we know that there are disparities. We know that because feeling like a burden, feeling hopeless, and feeling invalidated as a person are some of the cognitive risk factors, as well as having access to lethal means and having experienced trauma or abuse, or all these things that are increased risk factors. That there are some groups that experience systemic, disproportional injustice, and therefore are at higher risk. If you're part of a cultural group that has experienced kind of either disproportionate oppression or lack of opportunity, those, especially in the last 10 years, have been shown to be associated with accelerated suicide risk. Again, if you look at laws and policies that have been enacted in recent years, those that sort of question the validity of a particular group or a particular person are associated with major increases in suicide rates among youth in those groups, whether we're talking about trans youth or LGBTQ youth as a whole. We're seeing a lot of increase in those risks, and they're not small increases. They're major increases. There was a ringing the alarm report for looking at Black youth under the age of 12 are shown twice the rates of suicide of white youth. And you see the rates within the groups that we're talking about, and American Indian, Alaska Native individuals are 3 times the rate of suicide among any of these racial groups that we've seen, and the rates have not gone down in recent years. So if you look at all the public health issues, all the crises, all of these things, we've seen major reductions from our research, from our clinical efforts to drive down these rates. But unfortunately, we're not seeing that among among suicide, because I think you have a combination of population health and healthcare factors that make these things challenging.
And then I think to continue on to that, what I'm hearing is that don't rely on the gut instinct or like, maybe this might be a situation in which we're setting ourselves up for some bad outcomes, but to really think about universal screening. Can you talk us through the importance, John, and then maybe we can also, Elizabeth, jump in as well too, through thinking about how we screen for suicidal ideation or suicide behavior in the general pediatric population? And then maybe some practical tips or language that clinicians can use, because sometimes even saying the word suicide can feel really scary.
Yeah, we'll try to break down those questions. Those are like some great ones that you added. I mean, the first piece is that suicidal thinking is present in about 1 in 5 high schoolers, according to multiple national anonymous surveys like the Youth Risk Behavior Survey, and that's been present for many years. So even though there have been some increases, it's common. We also know that only about 1 in 4 parents are aware of this. So we've got a big disconnect. And I'm not talking about out of touch parents who never have conversations with their kids. I'm talking about good, normal parents that do a lot of good things. Unless you proactively set the stage and make addressing an emotional crises and or suicidal thinking part of the norm, part of something you just do, just like you talk about other behaviors like online safety or bullying, or ideally you're also talking about things like sex education and what are you doing, and substance use, and you bring these up. I think we want to set the norm that we're going to ask these questions, and then it's even more powerful when your primary care office or your behavioral health provider or your school counselor is also willing to ask very direct questions about depression and suicidal thinking. So the key is, in terms of a conversation, it would be even better to have this happen before the first time you get this as a screener in a medical office. However, it's still really important to do this screening. So it's a combination of, I think, of public messaging and then doing the right thing in our healthcare system to support that. So I'm kind of take that two-pronged approach, and then there are definitely strategies for asking these questions. You do want to give the young person some privacy. You want to make sure they have a place to be able to talk about this. You want to validate that there is no right or wrong answer. Having a thought of wanting to end your life or not doesn't make you a better or worse person. It means you're either experiencing this level of emotional pain or you're not. And I'm going to be there with you to support you in coming up with next steps. I'm not going to treat this punitively. If we may very well have to share this with the trusted adults in your life. And we're going to do that together. And we're going to come up with solutions for something that has been causing you to struggle for a long time. But it is that stance that you take. And I noticed the first time Elizabeth started talking about it, she already had that idea that we're going to do this together. We're going to join together. And that's, I think, it is sort of, something that's not easy for a lot of folks. We do a lot of training for schools and providers in healthcare. So to answer that other question, and then I'll stop talking. I want to make sure that the folks know this isn't easy. It is a muscle you can build. It can be built through exposure, which is practicing saying that words aloud. We've asked literally hundreds of thousands of kids in our system, have you ever thought about ending your life? Or have you thought about specific ways that you would harm yourself? So once you do that, you feel more comfortable and confident, especially if you know that there's something on the other side. So I know we'll spend time later thinking about what next, but you're not going to ask that question unless you have a clear idea of what next. You're going to avoid it as a provider or a teacher or a parent. If you don't know what's next, you're just not going to ask the question. So it is all about preparation and practice.
And before we move on to maybe Elizabeth to help us get some language around this, what questionnaire, what screener, can you give us the names of what, I should be using in talk with adolescents, young people, children, to make sure that I'm capturing the data that I need to help them?
Yeah, I think one of the measures with the best properties around its measurement, around identifying people who are actually at risk and not over-identifying, is the Ask Suicide Screening Questionnaire, or the ASQ. Actually, it's at NIMH and Children's National, Nationwide Children's Hospital, Boston Children's. They took all of the potential depression and suicide questions that typically predict suicide, but that could be 50, 100 questions, and they were looking to boil it down to the fewest possible number of questions that could be used in an emergency care setting, and they came up with 4 questions. And they looked at specific thinking and specific behavior questions. And then if there's a yes to any of those, they ask whether you're thinking about suicide right now. So that ASQ is a really good tool. There are other ones. The PHQ-9 is a good tool. It's specifically a good depression screener. It does struggle with its prediction of suicide risk compared to the ASQ. So our recommendation often for healthcare settings, primary care, behavioral health settings, are you should screen for depression when you're looking for depression, screen for suicide when you're looking to screen for suicide, and that ASQ is a good tool for that, and it's actually valid from pretty much age 10 to through adulthood. So it's a quick and easy one. There are some other measures as well out there. The Columbia Suicide Severity Rating Scale, and that screener is a helpful tool. We use that as a risk assessment tool. But yeah, there are a number of other ones, and I can add those in resources.
That's perfect. So let's use the ASQ for now, because it sounds like definitely a standardized test that's popular everywhere. So let's say, in Elizabeth, we're going to put this over to you now. Let's say that Aiden screens positive on the ASQ. So once that initial screen is positive, how do you approach assessing acute risk and determining the next steps? And as John was saying, we got to be ready with our next steps if we're going to ask this question. So what are the next steps that we can do, and what's the kind of approach to assessing that risk?
Before I answer that one, can I selfishly jump back like one step and talk a little bit about screening as well?
Sure.
Just very briefly.
Yeah.
But this is something I'm very passionate about. I want to just really emphasize a wonderful point that John made earlier in the episode, which is just that initial disclosure can be so difficult for the patient, but yet so meaningful. So in my practice, my agency setting does use the ASQ. So I'm very, familiar with that tool, and I find it to be a very useful one. There are also some kind of verbal techniques that I use in my practice to maximize the disclosures that I might get of suicidal ideation. So the first thing that really works for me is providing a bit of normalization. So I will say something like, oh, I see, and hear that you're really depressed. That must be really hard. Sometimes when people are depressed, when they're overwhelmed, they might have thoughts of killing themselves. Has that ever happened for you? And giving kind of that normalization at the beginning, I have found to be very effective, because it immediately signals to the child that they're not alone. They're not the only one who has had these thoughts. And in fact, it would be, an understandable reaction to being in emotional pain. And using the language of like we can also be really helpful. So like sometimes when when people, are in distress, they have thoughts of hurting themselves. Like, has that happened for you? Is a really powerful shift to show them that they're not alone and reduce the stigma. A second verbal technique that I have found to be very effective just to elicit that initial disclosure is being explicit about de-emphasizing the person's level of attachment or intent with the thought. And this is an interesting point, because I will often have kids say, no, I've never had suicidal ideation. But then if you probe a little bit more, you find out that they actually have, but they said no because they didn't have intent to act on the thoughts, or because they didn't think about it, in their opinion, very much, or they didn't take it too seriously. So I often will have kids saying, no, I've never had thoughts of killing myself, because they're attaching meaning in that question that is not actually there. So what I do to try and circumvent that is I'll say something like, has the thought of killing yourself ever come in your mind, even if you didn't necessarily think you'd act on it? And that can be a subtle but a very powerful shift, because if we think about the way that cognitions work, sometimes thoughts just do come in our mind, and we're not quite sure how they got there. We don't dwell on them too long. That doesn't mean that they stay there for, days and weeks on end. Maybe they do, but also maybe they don't. So using that shift can be very helpful just to get as many initial disclosures as possible. So we have a disclosure. How do we risk stratify? So in my setting, I use a tool called the Columbia Suicide Severity Rating Scale, or the Columbia. I find that to be a very helpful tool. It is evidence-based. I'm going to give just a general overview in my experience of how I would approach a risk assessment informed by, the Columbia tool, but also just integrating some of my own practice as well. So I would say that there's 4 important steps for risk stratification. I would say step 1 is just getting a basic history of the SI or suicidal ideation in a way that you would for other medical problems. So when was the onset? How frequent has it been? How persistent has it been? And kind of what's the level of imminency of the thoughts? And when I say imminency, I mean kind of propensity towards action. We can think of this like a ladder with a couple rungs on it, ranging from quote unquote lower imminency to higher imminency or immediacy. So at the bottom of the ladder, we have thoughts of wishing to be dead. Then next on the ladder, we have thoughts of killing yourself. That progression is meaningful. Then next on the ladder, we have considering a certain method to end your life. Next on the ladder, we have any amount of intention to act on the thoughts. And as John mentioned, it is often partial intent or ambivalence. Any amount, even 1% of intention is notable. And then finally, the top step on the ladder is there a plan? That's step 1 of our risk stratification. What's the basic history? What rung on the ladder are we? And I would also add in, has there been any past suicide attempts before? Step 2 of a risk stratification, I would say, is assessing for additional co-occurring risk and protective factors. The nature of the suicidal thoughts themselves is only one part of a risk assessment. It's an important part, but it's not the only part. Looking at other risk and protective factors that either increase or decrease the likelihood of suicide is also important. Key risk factors that I would ask about are, is there a family history of suicide? Does the person have a history of non-suicidal self-injury? What are their co-occurring mental health symptoms? And I would, within that, ask about mood. And I would also ask if there have been any command hallucinations, hearing voices in your head that are not truly there, telling you to kill yourself or hurt yourself in some way. And then I would also ask about access to lethal means. What do you have access to that you could use to hurt yourself? Not necessarily putting ideas in their mind, but if they have shared with you, I had suicidal thoughts yesterday and I thought about XYZ, maybe asking them, well, do you have XYZ in your house? Tell me more about that. And that would increase the risk. Some key protective factors that I would look at are, do they have reasons for living? Do they have social support from family, from friends, from teachers, coaches, whoever it might be? Are they in any treatment? And then are they future oriented? Meaning that their thought process indicates they will continue to be alive in the future. They might say something like, next time I come back, I'm not going to talk to you again. Great. Next time you come back, you're still going to be alive. You're telling me that you're still going to be alive and you're going to come back and you're not going to talk to me. That's kind of part 2. So we have our imminency of the thoughts. We have our co-occurring risk and protective factors. Part 3, I would be looking at their observable mental status. What do you see? What's in front of you? How's their affect? How's their regulation? How's their thought processing? What is notable there? And then finally is engaging the patient and their family in safety planning. And we're going to talk more about that later in the episode. But in short, we want to see how well can they problem solve and develop a plan to keep the person safe. So I would say, I know that was a long answer, but I'm going to try to kind of bring it back here. We've got 4 parts of this assessment, broadly informed by the Columbia, but also kind of with some practice experience as well. And our key question here is, do the risk factors outweigh the protective factors? We've got a seesaw and we've got risks on one side. We've got protective factors on the other side. Which direction is it tipping in? And what the particular risk and protective factors are will look different, perhaps for each patient. But our central question is, what are the risks and are the protective factors, both internal and in that person's environment, strong enough to keep them safe?
Is there anything that's an automatic black, white, this patient should be directly sent to the emergency room versus this patient can stay with me? Is there any, it sounds like this is a spectrum. So is there like, ooh, this port on the spectrum? If that's not the case, that's good to explain to our audience as well, because I think we should all understand that there is nuance versus this is the thing you're supposed to hit.
Oof. Okay, I'm going to do my best to answer that. And John, please jump in. But I would say, is there anything that's black and white? For me, as a social worker, not really. But for a pediatrician who might not have quite as much comfort or experience with this, my answer might be a little bit different. I don't know if that's fair for me to say.
Very, very fair. Very fair. We are not trained in this. Even this is why we are looking for help. We are hoping to learn as much as we can, and we also want to play things safe. So yes.
If I was speaking to a pediatrician audience, I'm never going to say with 100% certainty, but the big ones for me would be, do they have current in that moment suicidal ideation? Not 2 weeks ago, not a month ago, not yesterday. Do they have suicidal ideation right now? And does the family and or patient feel unsafe going home? That's a big one. Okay, right there. I personally, as a social worker, have sent kids home for outpatient management with current SI, but with more training, with more experience. If I'm speaking to a pediatrician audience, if we've got SI in the moment, especially if they've got SI with a method, with some intent, I would say that's an escalation. 99 times out of 100. So might as well just call it 100.
Great.
Another big one is their mental status in front of you very concerning or unstable? You know, if you're dealing with a kid who is really dysregulated, really tearful, really unable to kind of re-regulate, even with support, and they're telling you that they've got a history of recent suicidal ideation, for a pediatrician audience, that would be a big red flag, I think. If your mental status in front of you leaves you concerned about sending that child home. Another big red flag, I would say, is access to lethal means and is at home, and especially if the child is talking about a very high lethality method. So if we think about, and this again is an adult audience, so I'm going to be a little particular, but try not to say too much. For example, if we think about firearms, that would be something very, very important. If a child is talking about firearms, if there is a firearm in the house, if there's a firearm maybe in a parent's house, a co-parent's house, and they spend time at two different places. If we're talking about, again, other very high lethality methods, certain medicines, the child maybe has a history of attempt with a certain method in the past, they're talking about using it again. The family is unable or unwilling to remove access to that. That would be a big red flag to me. And then probably the last one that I would say is if the child and family are unable or unwilling to safety plan. So if we've got a child who is expressing suicidal ideation, they're presenting as pretty hopeless, they're saying nothing works, it's not going to get better, and you try to engage them in making a safety plan, and they are either unwilling or unable, meaning that they, are willing to try to answer your questions, but not really able to come up with any coping skills, any adult supports, anyone that they could go to for help, any reasons for living, that would also be a big red flag to me. Those are probably the big ones. I don't know, John, what do you think?
Yeah, I think the one thing that Elizabeth pointed out is that many good risk assessments are often incorporating information from the safety plan. Mm-hmm. So we think about these things as linear, like we go from screener to risk assessment to safety plan to assessment of risk and protective factors. But actually, we may not understand the full level of risk until we explore the potential to engage in safety planning. So the stance of clinicians, most trauma-informed clinicians, are let's maintain this young person in the least intrusive environment possible. Let's maintain their autonomy. Let's help them know that they have a say in their mental health care if they are at all capable of remaining safe. So a lot of those questions, when you get down to it, I think Elizabeth framed it well. You may be working with a set of different possibilities when you're getting to that point of safety planning and sort of whether that escalation of care is necessary. You're certainly hoping that you can maintain this young person in their home environment if at all possible, because it's not a wonderful experience to go through many U.S. emergency care settings when you're dealing with a mental health crisis. So if we can help them identify what they can do to stay safe, sort of delay, distract, support, build trust, know that they have other resources, that's really good. And then luckily, we're starting to build out our infrastructure, things like mobile crisis, things like calling 988, suicide and crisis lifeline. There are more options for a person leaving care than there have ever been before, but that's still it's still a lot of discomfort. And so what often happens is a provider who's uncertain uses the entire hammer, and they say, well, I'm just not 100% sure. Let's send them to the emergency department. And I have to say, there's a lot of studies that show that that's not typically the most effective outcome if you can maintain someone safely in a different setting. So part of what we're trying to work for, and there's actually a pretty a big study at our center looking at how we can help primary care providers and healthcare providers increase their internal capacity to manage risk so that they're not managing or not sending their folks out or calling 911 or using coercive strategies. So again, that's a separate topic probably, but the idea is let's try to maintain this young person in the least coercive way possible so that they have some say into it and then go from there.
So that's a perfect segue to the safety plan itself, right? So what is, John, you kind of pointed out that, okay, we need to have the safety plan in place to actually give us that risk benefit balance. So maybe Elizabeth, can you talk us through what a safety plan is, what you put in a safety plan, for example, how we create a safety plan, and then we'll take it from there?
Yeah. Safety plan in general is a plan that a child and their support system, often including their family, will put together to keep the child safe. And this includes usually a couple different components. It includes warning signs or triggers that suicidal ideation might recur. So, for example, if a young person knows that getting a bad grade on a test is a trigger for them, that might be a warning sign that they list in their safety plan. It's things to be mindful of that we can be on the watch for that might increase the risk of these thoughts coming back. It also can include ways that the young person might show outwardly if they are in distress. So, for example, if a young person knows that when they're in distress or if and when they're feeling suicidal, usually what they do is slam their door, go to their room, and not let their family come in. That might be a warning sign for the family that the family should be mindful of. If they see this door slamming, if they see this self-isolation, that could be a clue for the rest of the family. That's kind of the first step. What are triggers? What are warning signs? Another important part is coping skills that the young person can use. I try to incorporate coping skills that are very realistic. Okay, so something that they can do in most places where they live and they learn and they spend time. Things that they actually have done before and know to be helpful, or that they're actually willing to try. I am always very open with young people when I'm safety planning with them. And I say, when we're thinking of coping skills, I don't want you to tell me what you think sounds good as a coping skill. I want you to tell me what's actually going to work. Okay? I want you to tell me what's actually going to work. If it is like picking at your fingernail within reason, that's what I want to put on the safety plan. If it is like fidgeting with your pen and clicking your pencil eraser, that's what I want to put on there. I want to put what's actually going to work, not what sounds good on paper. Sometimes kids already have good knowledge of coping skills. They can tell you, oh yeah, I love listening to music. Sometimes they don't, and you can work together to brainstorm with them. And there are some very good lists available online that could be a resource in these conversations. Another important part of a safety plan would be adult supports. This can be, I find, an especially difficult one sometimes for young people. They might identify that they don't really feel safe or comfortable talking to parents or to teachers or to guidance counselors or whoever it might be. That can be a bit of a pitfall. Ideally, we'd want to have at least one strong adult support at home and at school. If a young person is really struggling to identify those, I might talk about, how support can look different for, with different people. Maybe you're not willing to tell your mom all of the reasons that you are suicidal. You're not willing to tell your mom about your breakup or your grades or whatever it may be, but you're at least willing to tell her that you're unsafe. That is still very valuable. I will also sometimes explore things like using a code word where maybe the child is willing to open up to their parent, but they have a hard time verbalizing. We might work together and make a code word that the child can use to signal to their parent that they're having suicidal thoughts. I've also had kids agree to give a letter to their parent if they're having suicidal thoughts. And I've typed a little letter up saying, I need help. Please call 988 or the local crisis line, whatever it is. And I give it to the child and they agree that if they're having the thoughts, but they can't say it out loud, they'll hand it to their support person. Anything we can do, creative problem solving to get those support people involved. The last part of a safety plan is safety precautions in the home. So what is the adult going to do to keep the child safe from themselves? So this would be things like taking away access to lethal means, using a lockbox for firearms, using a lockbox for medications or knives or scissors or other sharp objects. If you have those available in your site, providing them can be very helpful, or finding local resources where families could get those for free or reduce cost. Things like increasing supervision of the child at home, having regular check-ins with the parent. I talk about the parent initiating conversations themselves about mood and about suicidal thoughts. So they're starting the conversation and asking direct questions, not waiting for the child to come forward. And there's some of the things. I fear that list just got really, really long. But the truth is, a good safety plan is individualized to that patient and their social system. The best safety plan is a realistic safety plan and an individualized safety plan. There are some good templates online of safety plans that are free, that are easily downloadable. That would be a great reference to use in your practice.
That's awesome. Thank you so much. That is a really applicable life lesson beyond safety plans of the thing you're actually going to do is always going to work better than the thing you want to do. I'm curious, I heard you talk a lot about parents, and I know in a lot of situations, teens are really hesitant to bring parents into this conversation if it's not a conversation that they've had before. So I'm curious, maybe starting with John, when do you involve caregivers? How do you involve caregivers, particularly when you know that patient confidentiality is something that you've often set up as an expectation at the beginning of the visit?
It does go right back to what you said. I think the best way to address limits of confidentiality is to have established it really early on that the young person's safety is your priority, that it may feel uncomfortable or there may be some preferences not to share information around specific thoughts or not wanting to be alive. And that can be scary to share with a family member if you haven't done so before. But we want to think about this as a team effort. Elizabeth said, leveraging the support of family members is so critical. I actually like the term collaborative safety planning even more than just safety planning, because it forces you to think about this as a team effort. Good safety planning is collaborative, and it really ensures that people around you are aware and can support that. And for young people, especially minors, those under 18, they're often living at home with caregivers who have the ability to support those safety efforts. So we frame it as a team effort. There are some things you simply can't not disclose to a parent if you're under the age of 18, unless you fear that by sharing that with the caregiver that would cause predictable harm. It's a high bar, and it's a very rare situation where you would not share information, and that often then warrants a report to protective services or something if you're going to go that route. Again, that is very uncommon, even though many children will tell you, I don't want you to tell them. Can I just tell you this? And you promise not to tell my parents. You cannot swear privacy and confidentiality around a child's self-injury risk. So we want to set that up from the beginning. And that's something you can do in a compassionate way. You can say, it's totally understandable that you wouldn't want to share this. You're being so brave for even telling me this in the first place. What I can promise you is I'm going to be there supporting you, and I will help you through any conversation that you have to have with your family. And when we do that together, we've had many of these conversations with other kids who are really nervous about how their parents might respond. But they're going to be on your team, and we're working together to keep you safe. And the parents then have their responsibilities too. After all this, they're going to have to make sure that they're managing access to lethal means. They're going to be checking in on your emotional health. They're going to be setting the stage for new routines that allow you to feel more effective in your day-to-day care. So it's got to be a team effort, and any treatment that doesn't involve parents and caregivers in the treatment of suicidality, I would be concerned about, because they do need to be involved.
You say, hey, I can help you talk to your parents about this. Do you generally speak to the parent first outside the room and explain what's going to go on and have them come back in? Or do you generally, invite them in and have the kid go for it and give them some coaching tips? And if some coaching tips, what would those be that we can pass on to them too?
So it's a really good question, and kind of a little nuanced, because what you don't want to do is go out and then relay everything that young person said to you in minute detail. So you want to maintain that trust. So it's typically, for me, it's a very brief conversation to allow them to have a moment to adjust and reflect and say, hey, we had this conversation. You know how we do some screening and ask questions about whether they've ever had thoughts about killing themselves or suicide? That could be a little scary. What they did answer is that they endorsed that, yes, they sometimes do think about that. And so we've had a good conversation. They've shared some things about what they do, what they've thought about. And we're at a point where we're thinking about how do we stay safe for the rest of this, for going home. So I think, and you might give them a hint of are we looking at potentially escalating care? So, but fairly brief. Again, I'm not relaying everything that the youth said, but I'm talking about the safety. And then I'm going to say, would you mind coming back in as we navigate the best way to keep your child safe? Or do you have any questions right now before we go in? Are you going to be? Is this do you feel comfortable going back in? Because what you don't want is sort of the parent launching an attack on the child when they come back, or blaming them and say, why did you share this? This isn't the way it is. So hopefully enough conversation to set the stage for, this is serious, but we're going to work together. Are you in a position to hear this? If so, we'd love to go back and start this process. But I'd love to hear if Elizabeth has any other tricks of the trade as well in this area.
Or Elizabeth, do you have any thoughts about, say you go, okay, we just kind of briefed mom, we come back in the room. Do you have any thoughts of how you set the kid up to explain it to mom, him or herself, or do you have the doctor go ahead and do the explanation first?
I will ask the child and the family kind of what feels best for them. So oftentimes when I'm doing my suicide risk assessments, I'm meeting privately with the child. I am giving limits of confidentiality at the very beginning, because that is how you set up a trusting relationship and a transparent relationship. And then if at the end the child is hesitant about disclosing to their parent, I will ask them, how can we work together to make this, possible for you? Do you want me to tell them first without you in the room? Do you want to tell them yourself while I'm here? Um, do we want to just take like a quick breather, 5-minute break before, we have this conversation? Like, what's going to make it possible for you to do this with my help? So, generally speaking, I try to follow the child's lead and the family's lead as much as possible. So if we're taking the example that John just gave, where we meet with the parent privately outside the room, we break the news, we give them a moment to process, we're providing that empathy. I'm usually saying something like, I know this is, maybe something you weren't expecting from this appointment. This is not something that's easy for you to hear as a parent. And I want to hold space for you just as much as I am for your child. And then once the parent is prepared to go back in the room, I'll kind of provide some structure. So I find that kind of like breaks the ice a little bit and kind of gets the conversation going. I would say something like, to the child, okay, I just told, your mom what we talked about. I gave your mom like a summary of what you shared with me, some of the thoughts you've been having, what's been going on, and, what the safety plan that we created is. And then I'll usually say to the child, is there anything that you want to add? Is there anything you want to say directly to your own parent? And then I'll also sometimes, especially if I've got a good parent, if I'm aware that I have a good parent relationship, I might say, Mom, is there anything that you want to say, to your child right now to tell them, how proud you are, how brave they were, kind of invite that dialogue to kind of leverage family supports as a protective factor. And then I'll just kind of move into talking through the safety plan. Usually what I do is I'll begin to create the outline of a safety plan with the child one-on-one, and then I'll bring the parent in to review everything, to get additional input from the parent, to find out like what's feasible in the home environment. Do they have anything else that they want to add? If that makes sense. I usually do my personal approach, and this varies by clinician, is to do a bit of the safety planning initially with the kids so there is some privacy there, and they can tell me about what is going to be effective for them. But then also to bring the family in for a review and for an addition. So I will print off the safety plan. I will be reading it through once it's finished with the parent and with the child. And I will be trying to provide just some structure for the two of them to have positive interactions. Generally speaking, I think if both parties are in a state where they're receptive to the discussion, this can be a really transformative moment.
I had one final question about our safety plan. We kind of talked about all the positives and all the things we're going to do when it goes well. Just in case when it goes poorly, you had mentioned one thing, which was hand them the envelope and say, hey, call whoever. That was just the one thing I was going to say in the bottom. Like, if doesn't work, is this call 988? Is this go directly to the emergency room? Is this call 911? What do you guys usually put as the bottom of, if we're having thoughts regardless of all the coping strategies and things like that? And sorry, I didn't point out to who to ask that question to. So, John, it sounds like you're ready to take that. So would you mind answering that one?
I'll just start with thinking that every system should have a plan on how and where they will manage their referrals. Knowing, are you going to have a emergency department locally? Ideally, is there a place that has skilled, more behavioral health providers in those areas? I think that's what you want to have, a bit more of a warm handoff. What you'd rather not have is just a referral. You'd rather not have just call, law enforcement or 911 or even 988 sort of that's a national crisis line, and it's sometimes connected to local lines or mobile crisis, but not all the time. So you want to have personal relationships and a workflow that facilitates a family supported process.
Gotcha. So if you're like, okay, we have we know we have a psychiatric emergency room or a crisis center somewhere, and then you have also let that group know, for example, ahead of time, hey, I'm safety planning with this patient of mine, and I, just in case this doesn't go well, they might be coming to you within the next month or so, or whatever it may be before you see them again.
Exactly. And just through quality improvement over time, like if you're using the same tools, the same measures, even just like 10 years ago, people were using all sorts of different instruments and measures, and you'd have to repeat the presenting issues over and over again. And the family and the young person in crisis, probably on the worst day of their life, has to keep telling new behavioral health providers what they experienced, the plan intends, and their safety plan, and why they couldn't keep themselves safe and all this. And the stories change very quickly, because once you sat in a waiting room for 5 hours, you also have time and space, which isn't a horrible thing, but you're also your motivation to share accurately, and if you no longer trust that the adults will meet your needs, things change rapidly. So if you have it all documented and you're using similar tools and you're transferring this information in advance, you can say, hey, we specifically identified this ideation with this level of risk, with this lack of ability to maintain their safety. I need you to take this very seriously, because even if their story changes now, this is the current day-to-day. I meant to say this earlier in terms of suicide risk. Suicide risk is more like an EKG than anything else. The level of risk fluctuates over time. And so when you get that person in front of you, you're just seeing them at a specific time when their risk is dynamic. And so the idea is you want to ask a few questions that capture a longer period of time, so you can at least capture the high points of that risk. But you're also understanding that that's going to ebb and flow. And so if you have lots of time points where you're asking these kids questions, sometimes they're like, no, I don't want to kill myself. And you know what? They're not lying, because they don't want to kill themselves right then. But you know what? Last night, when they had this fight with their friend, or they got dumped, or they didn't make the team, or they failed a test, or any of the many things that kids normally will experience in those teen years, they had a different experience, and their ability to regulate their emotions and the supports they have make a big difference. One of the hardest aspects of all of this is, even when we do perfect care, there are many factors outside of our control when it comes to depression and suicidality. I was just at a talk where they talked about at least 70-80% of the predictors of long-term suicide risk, not the short-term that we're talking about when we know, are predicted by things like population health risk factors, like housing, like food, like social determinants, and all these things that we don't manage in the moment in our healthcare visit, but we need to know about, we need to understand, and we can help create some safeguards so that despite those level of risks, we can build hope, we can generate some reasons for living, and we can help that person delay the decision to end their life, because even that delay gives them time to develop some alternatives and say, I can live another day, even under terrible conditions, or I can manage to get through this, because in the future, that even as a child, I'm in the valley and I can't see that it will get a lot better. I have this shred of possibility that things could get better.
I like that as a note to end on, right? That like we're really talking about future orientation. So yeah, let's sum it up. I appreciate all the information that y'all have shared. I guess if both of you could give maybe one or two big take-home points, if people take away nothing else, what would you like folks who listen to this episode to come away with?
There's so many takeaways. Okay, I'm gonna settle on two. Number one, being collaborative with the patient and family. I don't think I can emphasize that one enough. Trying to get buy-in and collaboration as much as possible will be life-changing. And to that end, it's really no different than other aspects of medicine. Collaboration and patient buy-in is always central. To go back to our discussion earlier about, kind of dispositioning, escalation to level of care, I think this is really one of the big burning questions for our audience. So I'm just going to repeat again, if you take away nothing else and you're doing a risk assessment, do the risk factors outweigh the protective factors? I think that's the question that it's always going to come back to. And in time, as a pediatrician, the more that you see these cases, you will develop more confidence in understanding that balance of risk and protective factors. I also just want to again emphasize, thank you so much to all the pediatricians out there who are trying to do this work.
And John, you as well. Final take-home points, if you could sum it all the way down to, to one or two.
Pizza.
Ask the question. Pizza. and then ask the question. This is a little bit of a loaded response, because to ask the question, you have to reflect on where you are as a provider. What do you have in terms of a comfort level and a set of beliefs around suicide? What are you bringing to the table? Do you believe that kids can think about ending their life? Research would say yes. I just read an article earlier this week about the fact that when you can ask preteens questions directly in terms of either verbally or through screeners, and it does not increase distress. It does not increase suicide risk over time. It actually makes them more likely to believe that there are people who can hear them say, I've been struggling with suicidal thinking, and get a validating, compassionate response from providers who can listen. So it is walking alongside of individuals, not solving the problems that have gotten them to that point. You do want to understand their drivers and get there, but it really is a process. And then the takeaway is people can get training, but systems need preparation. Each of the systems that you're part of has to help you on this suicide risk detection and follow-up journey. And there are increasingly a lot of resources out there to help practices do this work, this very hard work well. And it will be time consuming at times, but you're putting in the time that meets the need of the patient. So if we're treating the whole person and you had this crisis, if you had a emergency condition that, a person we could come up with 1 million of medical emergencies. No one says like, oh, well, I don't have time for that. That interrupts my workflow. I hear that a lot when it comes to suicide risk and depression. It ruins my workflow, or I wasn't trained to do that. I think we're all trained to help people. And so making sure that we prioritize this leading cause of death among young people and give them the chance to let an adult know, and then to start to grow one step at a time. Take a step to make your practice better, and don't try to be the perfect clinician right now. So I would just leave it with, do one thing to make your care of suicide risk a little bit better. And I think that's going to go a long way to keeping kids in safe and healthy.
And thank you guys so much for coming on the show. As you said, we're here to learn. And, by the end of this, if they do listen to this episode all the way through, we are going to be farther trained than we were just an hour and a half ago. Just before I let you both go, especially because there's a lot of resources in this area, anything that we should plug, anything that we should put in our show notes, hotlines, lifelines, anything, websites that people should check out, anything that we should have kind of listed out in our show notes as well, from a resource plug perspective.
Sure. I could send you an entire list of items. I think you've got like the simplest ones to remember are the 988 Suicide and Crisis Lifeline. Trevor Project is great for LGBTQ youth. There's resources for families. Our Center for Suicide Prevention and Research at Nationwide Children's Hospital has a lot of specific resources for youth, for practice, for families. The Kids Mental Health Foundation is a group that puts out a lot of information, including support for caregivers around mental health broadly, but around suicide risk, we've done some work on. So there's a lot of American Foundation for Suicide Prevention. So there's a lot of great resources. I could go on and on, but I think as long as there's a desire to keep learning and growing, that's great. NIMH does have a toolkit for the ASQ, and it's got translations of the ASQ in 20 different languages and toolkits and procedures, like how to actually do the things, from the screening to the risk assessment, and then the Brown and Stanley Brown safety planning intervention. As Elizabeth said, there are templates that do this, but please remember that the template is not the safety plan. The intervention and the collaboration with the family is the plan. So like an after visit summary is only as good as the ability for someone to apply it. So yeah, those are some of the resources.
And Elizabeth, is there any other ones that you mentioned other than that? Otherwise, we can put all these things in our show notes at the bottom, because especially templates are helpful for us as a place to start too.
I think that covered it perfectly.
Perfect. Well, guys, thank you so much for coming on. This is awesome. We've all learned so much, especially using where we always don't get trained in these as providers ourselves. And so getting that next step. So hopefully we can do some of this before, working with you guys collaboratively. We'll talk we have an integrated behavioral health episode as well. Please check out where we can talk about whether this exists in our clinics versus not, and what we can do to make all that happen. And all of those things is a long-winded way to say thank you so much for coming on the show.
Thank you so much for having us. This was, truly such a great conversation, and I'm just feeling more energized.
Absolutely. Thank you so much. Really appreciate it.
This has been another episode of the Cribsiders.
It's for the kids.
Get our show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
So we are committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producers for this episode, both Dr. Hartley Lidsky and Dr. Crystal Noira, and our wonderful social media team, which is mostly Dr. Denise Cruz on X, Blue Sky, and Instagram. I've been Sam Mazer.
I'm Hartley Lidsky.
And I'm Crystal Noira.
Thank you, and good night.